Good afternoon, everyone. I'm Dr. Vani Parekh. I'm a general ophthalmologist practicing in Mumbai. My topic is surprises on the eyelid, a reaction to an Ayurvedic treatment. So we had a case of a 71-year-old female. She came with a presentation of swelling on both the eyelids and her face. There was profuse pustular discharge from both eyes, inability to open her eyes. She had a history of cold, congestion, blocked nose since 4 days, watering from both eyes since 4 days. Her past history was she was a known case of rheumatoid arthritis since over 10 years, for which she had been on a certain Ayurvedic treatment for over 2 years. 2 months before the symptoms started, she had gone to a center in Kerala for a very specific treatment. This program was called SBA program for rheumatoid arthritis. It was science-based, evidence-based Ayurveda. It's very detailed, but summary was for the first month they cut off dairy, oil, ghee, fruits, coconuts, nuts, fermented foods, and only boiled vegetables were allowed in her diet. In her second month, some form of medicated ghee, details I couldn't get, but she couldn't explain it, but some medicated ghee, she said, it was introduced gradually from 10 ml to 80 ml daily over a month. The third month, she came back to Mumbai. She got a cold, after which, as part of her therapy, she was advised that she is not supposed to have a bath till the symptoms of the cold don't settle. She had a fever of 101 when she came, but on the day of presentation, she was afebrile. She didn't take any paracetamol, she just did cold towel compress. And HGT was 173, otherwise general parameters were normal. On ocular examination, pustular discharge, necrotic, erosive patches in areas of the eyelids, inability to open eyes. On forceful opening, the bedside vision was counting finger 3 meter. Pupils were round, regular, reactive, anterior chamber normal, lens seemed clear. This was a presentation when she had come. CT brain and orbit showed extensive diffuse soft tissue edema seen in bilateral, periorbital, and preseptal soft tissue, likely representing diffuse inflammation. No localized fluid collection seen, no intraorbital soft tissue fluid collection seen. The extraocular muscles were normal, orbital walls were intact and appeared normal, no intracranial abnormality seen. Paranasal sinuses CT showed moderate inflammatory soft tissue secretion seen in bilateral, maxillary, and ethmoid sinuses with soft tissue plugging of right osteomeatal unit. Minimal inflammatory mucosal thickening seen in the right frontal and bilateral sphenoid sinuses. Left frontal sinus was hypoplastic, osteomeatal unit of left maxillary sinus patent. Bony sinus and orbital walls intact, no soft tissue mass or bony erosion seen. Nasal septum was deviated to the right side and nasal turbinates normal. Cultural swab was suggestive of Streptococcus and Staph aureus, negative for fungal. In the emergency when she had come, the RMOs there gave injection Monosef before calling the ophthal. And then after she got admitted, there was an intensivist involved, I was involved, there was a dermatologist involved. So we gave injection vancomycin, 1 gram stat, followed by 500 mg. Injection fluconazole 40 mg. This was before the swab tested negative for fungal. A combination of meropenem and sulbactam. Moxiflox eye drops hourly, Natamet eye drops 6 times for 3 days before we knew it was negative for fungal. Chimoral 4 TDS, Levocet M and ENT had suggested. The dermat suggested a T-back cream and put Gelonet dressings and also gave linezolid. So this is on the 4th day of presentation. This was after 1 week. In the OPD on slit lamp, we saw thick hyperkeratotic crust. This is 1 week after her admission with erosive lesions over the upper eyelid. After a week, when we actually saw her vision was 6/9 and 8 when she was able to open. Early cataract, cornea was clear, fundus 0.5 cupping. This was 2nd week. By now she was discharged. She used to come for follow-ups. This is between week 2, week 3. And over time, by week 7, she was near normal presentation. So initially I was, since I had never seen a case like this before, I was assuming was it an odd case of orbital cellulitis, but I'm closer to believing it was necrotizing fasciitis. So yeah, thank you.
Thank you, doctor. That was quite an interesting case. So in her recovery time, was she still on the
No, of course not, of course not. Because immediately when she came, the first thing we said is stop everything.
Yeah.
And her family members were also against it in the first place. Like, so everyone talked her out of it right away. So, yeah.
So the picture that you showed, that was her presentation? Or
That was her presentation, the first picture. So she delayed for 4 days before coming.
She already had the symptom, but she delayed?
Yes, she delayed it. So,
what
4 days. This was in 4 days, she said this happened.
So what do you think was the cause? Why did this happen?
So I am not sure I have still not been able to figure out what was it. Was it the not having a bath for a week and not washing her face at all? Was it the oils that were given, or
so
was
any literature that you looked up which had similar cases?
I did not similar. I found cases of necrotizing fasciitis which was similar but extreme to the point of enucleation done or a fasciotomy done in certain cases. Everything I read up showed that surgical involvement was there. This just a little bit of debridement and IV medication cleared up. So
you should have just included whatever literature that you have, so that we can compare.
Yes.
There has to be a learning from every
yes,
case,
that's
right?
true. Yes,
so we should be
yes,
able
you
to,
should have added that.
yeah.
So what was the final diagnosis in your case?
I believe it was necrotizing fasciitis because it looks closer to that than.
Blood culture, anything?
Blood culture showed, no, blood culture, nothing specific as such. WBC count was high. I should have added that as well. The WBCs were high. Otherwise, CBC was normal.
And did they blood culture kiya hoga? Any
No, no. Just a swab was done. Blood culture as such not done.
We are giving the top line antibiotics. We should at least try to look for the organism and what is it sensitive to.
Yeah, that's true, madam. There is a program going on in India and across the world, antibiotic stewardship program. We should not jump into higher antibiotics until and unless proved otherwise.
That is true.
We should always go for a culture sensitivity report. So you should always take a material from the involved site and then wait for the result and then start.
So here I have to say the patient was, in spite of everything, was not primarily under my care. He was under a physician. She was
no
under.
excuse, madam.
Yeah, I agree.
I mean, we can still guide, na? If you've been called in for an opinion, you must give your opinion.
He was a very senior intensivist and I was just doing my bit there in the hospital. But yes, you're right.
You cannot say intensivist is above ophthalmologist.
Ophthalmologist,
okay? We're all there
yes.
at par. Okay.